Hello everyone, my name is Dr. Denise Ejo, the CEO of Cornwall Cancer Foundation. I would like to welcome you to our Cornwall Cancer Foundation page. Our goal is to create an awareness of the challenges, support and guidance experienced in managing cancer care for sufferers, family, carers and friends. To engage with us, don't forget to subscribe to our channel, click our notification bell.
Good afternoon, everyone. My name is Dr. Denise Ejo, the CEO of Cornwall Cancer Foundation. I am welcome you all to the 2021 Let's Talk About Cancer series. And today we're looking at the challenges of people with cancer and COVID-19 and how to support them. Today we have two guest speakers, Dr. Ngozi Onoha and Mrs. Marian Pashabon. I think I've got it. Welcome to the house, both of you. We really look forward to having the chat. And because I'm on the train, I'm going to go quiet while they start the talking, and then we'll come back on it later. Okay, so Dr. Ngozi is a medical practitioner in the United States. And so she's going to be starting and talking to us about cancer and COVID-19. Dr. Ngozi, welcome to our platform, and we look forward to listening to what you have to say. Thank you.
Thank you so much, Denise, for inviting me to give this presentation. Today is really special because it's World Cancer Day. And technology is amazing because here you are on the train, on your way back from chemo. It's just incredible. So thank you so much. I'm going to be talking about the challenges of cancer during this COVID pandemic. So I'm going to talk on a few things, and I'm going to talk about this from the Nigerian perspective, and I'm also going to talk about this from the global perspective. And even though we've had this really disastrous virus that has caused so much disruption in everything, some benefits have come out of it. So I'm also going to talk about the good perspectives. So I'm going to talk about the bad perspectives of this COVID pandemic, and I'm going to talk about the good perspectives of this COVID pandemic, and then we'll take questions. So I'm just going to talk about the direct effect of COVID-19 on cancer. So as we know, cancer patients have more risk due to multiple factors. They have more risk of severe COVID disease because of many things, which include the active or progressive stage of the cancer, advanced age, poor performance status, comorbidities, and depending on the type of cancer, the outcome from COVID could be worse. If a patient has leukemia or lymphoma or myeloma and contracts COVID, their outcome will be worse. There are other factors that adversely impact recovery from COVID in patients with cancer, which includes active or ongoing chemotherapy, recent bone marrow transplants, and radiation therapy. So these are some of the things to take into consideration. We know that COVID is a terrible multi-systemic disease that can affect people in various ways. Some people will have a mild infection, they don't need to go to the hospital. Some people have a moderate infection for which they may need oxygen. And for some people, they have severe infections which needs oxygen and or intensive care therapy and ventilators. And people with severe COVID don't tend to do as well. They have more complications, higher risk of morbidity, mortality, and just all kinds of barriers to recovery. So just to give you some information on how COVID-19 affects cancer patients. So let me talk about some of the challenges that we've seen during this COVID pandemic, and I'm going to divide it. And I'm going to talk about it from the Nigerian perspective, and then I will talk about it from the global perspective. And then I will talk about the bad things that the pandemic has done, and I will talk about the good things. So when we look at the bad perspective, the pandemic has caused lockdown, as we know. And this lockdown has resulted in delayed access to care, delayed care. A lot of people have delayed their care because they can't get to the hospitals during the lockdown. From the Nigerian perspective, we know that oncology in Nigeria is not developed, it's not advanced, services are limited. For instance, the radiotherapy machines are not updated and scarce and expensive, so not easily accessible and not easily available. So patients seek medical tourism. They go abroad for care. They go to Asia, North Africa, South Africa for care. So during this lockdown, as we know, airspace was shut down and nobody could travel anywhere. So people got stuck. Those people that received their cancer therapies abroad, they could not go. So that hugely impacted care. They now had to seek resources locally, and some of these resources were not available, and this resulted in delayed care. So that is one major factor of how the COVID pandemic affected cancer care in Nigeria. The second major issue is that of funding and payment for cancer therapies. We know that cancer is very expensive. In fact, someone gets cancer, it can be the dividing line between being rich and poor overnight. So cancer has resulted in people going bankrupt in just one day. And we know that the funding for cancer comes from NGOs and crowdfunding from families, from well-meaning donors. Now, during the pandemic, we've experienced a global recession. Everything shut down. Everything has dried up. There's no funds, there's no revenue. And then we know that in Nigeria, a lot of the health insurance companies, they do not pay for cancer treatment. They don't pay for chemotherapy, they don't pay for radiation. And these are out-of-pocket expenses, and majority of people cannot afford it. If you have somebody in Nigeria who relies on crowdfunding or diaspora funding, people in the diaspora have also been affected. People have lost jobs. And we know that this pandemic has created real, disruptions in healthcare. So we know that a lot of people have died, and with that, loss of income for the families. So huge economic implications in being able to afford cancer treatments in Nigeria. Other issues include staffing issues. We know that the healthcare professionals have been disproportionately affected by the COVID pandemic. We've had a lot of deaths of health professionals in Nigeria. And so this has also resulted in reduction in access to care. Quality of life issues, the social isolation, inability to get out, lack of family support during this time for cancer patients. You know, somebody going for chemo in Nigeria, they cannot go by themselves and they may not have the support due to the lockdown. And people are afraid, really. They're afraid to go to the hospitals. So that is what we're seeing in terms of the bad adverse effects of this pandemic. Now, let me talk about some of the good perspectives in the interest of time. So like everything, disruption creates innovation. So unless there's a need, people do not feel the need to change protocols and policies. And typically in medicine, to change anything, to change workflow, it's a very slow process because there's so much pushback. People don't like change. They like what they like. And if you try to bring something different, even though it could be better, they push back. But with this COVID pandemic, we really had no choice. And the buzzword was pivot. Everywhere you went, if you wanted to succeed, you had to pivot during this pandemic. So what this pandemic did from the Nigerian perspective, you know, I spoke to a doctor who provides cancer care in Nigeria. And what he said was that it caused telemedicine to spike. So more people were getting consults via video calls, and they were getting their follow-ups via video calls. So removing the need to come into the facility. So that sort of accelerated, the services of telemedicine accelerated in Nigeria. Another area where this COVID pandemic had a positive impact in cancer care is in education. So previously, you know, cancer patients are very complex. You need multidisciplinary teams to get together and discuss the patient care and come up with the right treatment for each patient. Each patient is unique. So typically this is done in the context of multidisciplinary meetings, and they're usually in person traditionally. However, with the COVID pandemic, and because people could not gather in groups, they had to pivot again. And so that came in the form of virtual meetings. So now he told me they're meeting every week. They have weekly tumor board where they discuss the patient, they discuss a treatment plan, they meet with consultants. So that has really been very good for the patients. Now, abroad, a lot of things you know, happened with the COVID pandemic. For instance, in Philadelphia, where I live here, the university health system that offers home infusion services, before the pandemic, maybe they had 3 patients that they were going in to give chemo in the home settings for various reasons. Maybe the patient can get out of home or can't drive. So this was not really their main method of delivering chemo. But during the pandemic, because they could not get the patients in, there were very much a lot of challenges with getting patients in. They now expanded home infusion services where nurses would go to the homes and provide chemo in the home setting, chemo infusions, injections. So that was actually a good thing during the pandemic. Some of the bad things in terms of access to care, we talked about that, reduced doses to adjust for, you know, there were issues with supply chain, lack of medications because of the global lockdown, lack of supplies again during the lockdown due to supply chain interruption. Another issue was postponing surgeries, and the reason was because the hospitals were full, the intensive care units were full, and if a patient has major surgery and needs post-op intensive care stay or care, this had to be considered. And before you take a patient into surgery, you have to make sure that you have the ICU bed to take care of the patient. And so I think that in a nutshell, pretty much is everything I wanted to say. I think I will touch briefly on the vaccine currently, the COVID vaccine for people with cancer. Currently, the experts say that most patients with cancer or history of cancer should get the COVID-19 vaccine when it is available. Currently, we have the mRNA vaccine, and we have attenuated vaccines using particles or protein of these are not live vaccines. Of course, you cannot give live vaccines to a cancer patient. You cannot give any live vaccine to a cancer patient. But currently, the vaccines we have now, at least in the United States, are not live vaccines. So I think in summary, I think that the stakeholders should continue to amp services available to cancer patients in Nigeria, improve the infrastructure, electricity, to be able to deliver simple care, basic care. And we need to continue to dialogue to improve the healthcare system. Thank you.
Thank you very much, Dr. Ngozi. See, perfect timing. Perfect timing. First part of the journey, and I am able to reconnect. So I am now going to look for, because we're going to do questions and answer after this, I am going to be looking for Mrs. Marion Fashogmo. Are you on? Please tell us you're on.
Yes, I'm on. Can you hear me?
Yes, we can.
All right. Good afternoon.
Mrs. Marion Fashogmo is also a medical, what we call, okay, she's actually supposed to be a nurse practitioner. I always crack the joke, she's a doctor nurse. But whatever it is, she has a wealth of experience, both with cancer care and especially currently she's working continuously with the A&E departments, helping to help us cancer patients as we come in on all our emergencies. So Reverend Fashogmo, you have, sorry,
Mrs. Fashionable, you have,
Thank you. Whichever.
it doesn't matter, whichever way I call it, just take it like that.
It doesn't matter.
You got 5 minutes, 10 minutes to talk about cancer care and COVID-19.
Okay.
And then I will start taking questions. So once that's ready, I'll start taking questions. Alrighty.
Yeah, thank you.
I'm going on silent and video off.
Okay. Thank you very much. Thank you for the opportunity. Good afternoon, everyone. Like I've been introduced, I'm a nurse practitioner at A&E Darren Valley Hospital. And I'm a general nurse practitioner, so I'm not an oncology person, but I do come in contact with cancer patients from time to time. So I'm going to talk from the nurse's point of view, what we have seen and how we have been able to help at this time. It has been a very challenging time for us nurses. And actually it was like, we did not prepare for this. Nobody prepared for it. Even the NHS didn't prepare for it. So I'm going to look at challenges generally. The first speaker has spoken about a lot of stuff, which I don't want to go into. But I'm going to look at what challenges we faced in the NHS here in England. And some of the challenges we faced was decline in cancer screening, diagnosis, tests, delays in having cancer surgery, which meant that people cannot know when to return for their treatment. Appointment being rescheduled and being delayed, that was a problem. And then we had shortage of staffs, which because some of them caught COVID and they had to go and isolate, some of them have to shield, and some of them are on long-time disease problem, and as a result of that, like people with asthma and underlying problem, they have to shield. So we have that challenge of staff shortage even during COVID. So in England, what we notice here is that there were lots of things that impacted COVID. And I went to look at British Medical Association that had published a paper in July 2020. That was during the first COVID challenge. And what they came up with was the full impact of the drastic reduction in routine NHS care in England is now emerging. They came up with it that in order to free up enough capacity to deal with the initial peak of the pandemic, the NHS was forced to shut down or significantly reduce many areas of non-COVID care during the April, May, and June 2020. This combined with fewer patients seeking care during lockdown means that there has been a significant drop in elective procedure, urgent cancer referral, first cancer treatment, and outpatient appointment. And this was a paper presented by BMA, British Medical Association, and that was in July 2020. And they wrote the hidden impact of COVID-19 on patient care in NHS in England. So it really, really has a knock-on effect on us in England. And these are some of the statistics they came up with. The BMA estimates that between April and June 2020, which was very alarming, I never knew that, we have about between 1.3 to 1.5 million fewer elective admissions that would usually be expected. So there's a drop in it. And then they came up with it that they have about 274 to 286 fewer urgent cancer referral. That's the ones that come through GP from the community. So there was a drop in that. And the knock-on effects that we do in the hospital with the oncology and the cancer area, they're not getting the amount of patients that they used to significantly get. And they said between 12,000 to 15,000 fewer patients starting first cancer treatment following an urgent care referral. So it was actually a sad case, because some of these people, what we found out is that when they drop into hospital, especially in my area in A&E, and they came in, some were able to come in, some would not come in because they're scared of coming to hospital at that time. So some of the ones that come in, and we found they're very unwell. Usually we did all we can in A&E, but a lot of them need to move on. Some of the time they have to stay with us in A&E for a longer period that they normally would stay, because there are no intensive bed care, because there are no beds available, because COVID has impacted. So that was a knock-on effect that we have, that we notice with regards to patients. So a lot of time we just have to like reassure, do all we can in our emergency care area, which is not really the best area for them. But because of this, there isn't much we could do. Also, we noticed that there were a lot that were stressed, or even coming to the hospital was a problem for them. There was the fear that they don't want to come in because they don't want to catch this deadly disease, because it's been announced daily how many people are being killed. But they came on, some came on, and we reassured them we've got things in place, and which we have. We have to put the things in place to make that the environment is safe enough for them, and that sort of gives them reassurance. But again, it's all this that we have in place in A&E and in the hospital generally, because the first point of call is A&E. We found out that in UK, we have a lot of challenges during COVID. And the challenges sort of open us up to see that we have not prepared for a lot of things. And so at the moment now, a lot of things are being done in order to make sure that cancer patient doesn't miss out. Because if cancer is not diagnosed on time, it comes to be a problem. If cancer treatment is delayed, it has a knock-on effect. So all these are the things that we notice. But from nurses' point of view, all we could do is to give some health promotion tips and to advise patients that please, no matter how you feel, please come for your appointment. Still try to come for appointment. Keep up with your appointment. Some appointments were being made virtually, which helped. And so from there, whoever they can bring in, they bring it in. And a lot of other things we noticed in the hospital that we have to come in and sort of give a kind of health promotion is we as nurses, which we can't do much except to advise, except to reassure. We have to tell patients when they come to us from that point of view, and we've given them the first treatment that be vigilant, watch out for signs of infection. And once you notice that, get in touch with your team. Every cancer patient has a team. We are just emergency care for them, but they've got a team that they can come out. So please get in touch with your team. And we tell them, do good hygiene, practice good hygiene, which the government have put in place. Everybody knows that. Avoid large areas, wash your hands. And we also give them the health promotion of please eat well-balanced diet, because cancer kills cells, it destroys. So you need something to regenerate and help you to keep on top. So you need to follow whatever the your team has given you and have recommended for you to eat, which if you have a problem with that because of the kind of cancer you are going through, different things, and has affected your soul, please get in touch with your team and they can advise you or even refer you to a dietitian. Those are part of the things we advise when we see patients in A&E. And we tell them, if you don't have to go out, stay home as much as possible. Shield yourself so that you will be protected from the infection. Some people feel that they are bored, which is part of the problem that came up during COVID. People get fed up, people get lonely, people get stressed, people get anxious because they couldn't do the normal chores and things they do. So a reassurance was part of what we could do and give to them. And we tell them that make sure you have your medication in stock so that you will run out when you need to have them. Look after your mental well-being. That is one of the advice we give them, because I, as a nurse practitioner in A&E, have met patients that come into us and broke down. They came in with a different thing, but on the consultation, it came to light that the person has cancer. And this person actually discussed me and said, I should have had this surgery, but it was cancer. But now I'm scared because I'm thinking this thing has spread. And if it has spread, they may never be able to get it again. So all we can do with this kind of patient from nurses' point of view is to reassure them and to say, well, hopefully it will still be better, but there isn't much. So mental well-being was a big issue. Anxiety, fear, loneliness, depression. And of course, the NHS put some hubs out where people can get in touch. It wasn't like the time when you can be seen face to face. And then we tell them, stay physically active. Try and do some things. Some cancer will not allow you to do the right things because of weakness, but there are little things you can do indoors, even when you are locked down. You can be going, we advise, go up and down the stairs for activities, go into your garden, do some gardening. If you cannot go for walk, dance around in your home so that you keep up the body so you don't get that. But above all, after seeing them there, we tell them, please make sure you keep in touch with your team, because at the end of the day, they know you and they can do much more than we can offer you. So those are, from my point of view and from A&E, from what I've experienced, those are some of the things that we came across. Thank you very much.
Thank you.
Thank you.
Mrs. Fashogmon, thank you very much. Thank you to both our speakers. I am now back on my desk. And yes, I'm very sorry you had to go on the chemo journey back home with me. So let's move on to what we're doing for the rest of the day. And now you have the floor to ask as many questions. I will start with a question, but if you have any questions, please put up your hand. I want to thank both speakers, firstly, for fantastic introduction to COVID and cancer, because we have had a lot of issues. And I, for one, had one of my treatments canceled. So I've just gone back for a restart today. I think that was also one of the reasons why it was slightly harder for me to get out of hospital on time. So first question I'm going to ask, but if you have any questions, please raise your hand at this point, and I will connect you on. You don't have to show your face if you don't want to, but you can ask any questions you want. So one of the first questions that has come up is, cancer patients have not been able to get easy diagnostics since the COVID challenge. Now, the questions that are coming up is, how do they care for themselves in keeping safe? Because I'll give you an instance. I have had 3 people in the last 6 months who got diagnosed with cancer during COVID, and 2 of them have not, unfortunately, didn't make it. But one of them has actually had a very good story, because eventually she got the treatment and she got put onto a trial as well. So I want to ask now, as someone who's going through it, and I always say I live with cancer, no big deal, let's move on. But how do people, what are the things they need to do, irrespective of which country in the world you are living? What are the signs that you would say people should be aware of and come out and say, look, be able to talk to a doctor and say, look, forget it, I think there's something wrong. Please look out, tell me. I just need some guides, because for me it was just a headache. But I don't think that with COVID having its own issues and then cancer having its own issues, there must be something we can actually tie together to quickly know, this is not COVID, this is cancer, this might be something different, this is cancer, this, you understand where I'm coming from? So who wants to start? Should I start with you, Doki? Okay,
I'm happy to take this question. Thank you so much, Doctor. Thank you so much, Mrs. Faso. Did I get your name right?
Yes, you did.
Thank you. I really enjoyed listening to your presentation, and I learned from it, actually.
Thank you.
So back to your question, Denise. In terms of diagnostics, in terms of cancer, generally, we follow in clinical care. So I'm a clinician, I'm a generalist and geriatrician. We follow standard screening guidelines. And that is a very important part of cancer care, early diagnosis. So in cancer, early diagnosis is really the secret to survival. And we follow standard screening procedures. So for instance, for mammograms, we typically start, if there are no risk factors and nothing else, just a regular patient, we typically start screening mammograms at age 40. And these are done depending on the country, either every year or every 2 years. So starting age 40, every woman should have a mammogram. Now, there's certain other cancers that we screen for. Okay, one of them is lung cancer. So lung cancer, so I'm looking at the top cancers that are problematic, and the best way to survive is early diagnosis. So lung cancer, for those who are high risk, so smokers, there are some protocols that call for low dose screening CAT scans in those patients who are high risk for lung cancer. So screening is basically tests that are done before a patient starts to manifest the signs and symptoms of cancer. So screening means the person does not have any symptoms, just regular well check, go in, okay, 40-year-old female needs to get a mammogram. Colon cancer screening through colonoscopies starting age 45. Okay, we saw Chadwick Boseman die of colon cancer, and his cancer developed at a very young age. Right now, the current screening guideline for colon cancer, that is a patient that does not have any symptoms whatsoever, is 45 years, and thereafter every 10 years, depending on what they find. Prostate cancer screening starts at age 50 for men and is every year. So pap smears also for women starting age 21 and every 3 years, depending on protocols. So that is very important, the screening tests. Now, if a person has had screening tests and they feel fine, they just go back for the next screen. However, if a person develops certain symptoms, these are sinister symptoms, and they could include pain, unexplained weight loss, bleeding from the rectum, coughing up blood, vomiting blood, bleeding in the urine, abnormal skin lesions that look suspicious, that are not healing, night sweats, digestive problems. So anything that is new, persistent, bothersome, and unexplained and cannot be explained, then that person needs to see their doctor for a checkup. And that is when they start actively looking for cancer. This is no longer screening, this becomes diagnosis. So if a person presents with bleeding from a rectum, bleeding from the anus, blood in the stool, then they need to have a colonoscopy. They have weight loss. They may have an upper endoscopy as well to check for cancer of the stomach. So pain, unexplained pain, weight loss, night sweats. So like in your case, Denise, you had headaches, persistent headaches. They're not going away. They're not improving. Night sweats, like I said, loss of appetite. So many things can present with cancer. And another thing with cancer, sometimes cancer may not present with any symptoms, and a person shows up in the hospital and has a CAT scan for something else, and lo and behold, there's stage 4 cancer with no symptoms. So that's the crazy thing about cancer. Sometimes blood tests, with the tumor markers that people do, which we have CA, we have PSA, we have other tumor markers, and those could indicate that there might be cancer. But in some people, they may present with stage 4 cancer, stage 4 liver cancer out of the blue with no symptoms, maybe present with jaundice and no pain, and all of a sudden they have cancer. So it can be challenging to find cancer, but obviously the sooner cancer is found, cancer is, it goes in stages, stage 1 through 4. Stage 1 is easier to treat, and identifying cancer on time is cheaper. It's cheaper to do screening tests. It's better to get cancer at an early stage than find it at stage 4, which requires a lot of resources, a lot of funding, and without necessarily a good outcome. So I hope this answers the question.
Thank you.
Okay.
Mrs. Fajogmo, can you give us what you find from the nursing, from the coming into the hospital, especially to do with people that have struggled with COVID and cancer, you know, okay, I'll say what I'm trying to get at. A lot of people who have cancer, a lot of them have found themselves with COVID. Now, a lot of us with some form of either going through cancer, living with cancer, taking diagnostics of cancer, whatever, are really trying to shield and follow the rules, which is the rule of which is the guidelines that we've been given. Now, no matter where you are still prone because for any reason, a cancer patient may still have to go out and get their food, may still have to go and do basic things, even just get into the hospital. So, for instance, the only reason I was only wearing a mask today was because I have had the vaccine. If not, I would have had the headgear, everything. So nobody come near me, the gloves on. But that is because I can't afford to get my immune system shutting down on me. Okay, now for those who come into you from that perspective, I mean, how do you start to work with them? Because we know it is quite challenging, and there's no fixed rule. COVID is COVID. It's changing strains every minute.
Yeah, thank you. Yeah, I get what you mean. What we try to do, and from my angle, from where I work in my hospital, is if a patient comes in and already diagnosed to have cancer and they have other challenges, we try as much as possible now, because we've set out the department in such a way that there's a lot of isolation and we don't let everybody in anymore. So that spacing is there. And once they tell us they're already diagnosed with cancer, some of them are not on active treatment. If they're not on active treatment and we get them in and we ask them what's the problem and what brought them into hospital, we are aware of the fact that they have cancer. So we are very, very wary of that and how we treat them, because the environment we are anyway, anything may be flying around with COVID. So as much as possible, we get this kind of patients in and get them out. We don't let them waste time and stay a long period in hospital. And we've seen some that have come in that have been directed by 111 in England here, that's our own system here, and were brought in by ambulance because they have the challenge of COVID on top of their kind of cancer. So what we do is we go where we call isolation area, and we sort of put cancer patient in separate room, and not on a free ward. But we had challenge because when our separate rooms get filled up, we have to put them in the overflow area. But as well as I was saying, what we do is we get cancer patients in, they are a priority for us. So even with them with COVID, if it's the kind of challenge they're facing at that point in time that can be dealt with and sent to, they deal with them, send them back home in ambulance. If it's in the case of the one that have to be admitted, as much as possible, they look for where they need to go, where they will not be exposed to other patients so that they can at least be shielded. So those are some of the things we have in place. And to tell you the truth, it's been very challenging, even with our area where there is the cancer unit, which is called Pine Ward, where people come in for their infusions and therapies and get in. They had to close it down. A lot of patients have to come in through A&E, and then we have to get in touch with them before they can be seen by their team or consultants. So those are the challenges and those are the things. But now we are getting it better because I think we've learned a lot during the first lockdown and during the first peak. The second peak now is different ball game how they are treating it. And I can say, yeah, it's better for cancer patients now.
Oh, thank you. That's very encouraging.
Can I just add to it a little bit?
Yeah, go on.
Yes, I mean, during the pandemic, care was really put on hold. For instance, I saw a lot of my outpatients could not get mammograms because of the risk of exposure. However, things have opened up patients are returning for their screening tests. Now, those that need to see specialists, because again, the hospitals are mindful. When you go into the hospital, if you don't have an appointment, they won't let you in. They're checking temperatures at the door. Also, this is going on in Nigeria. They're checking temperatures because when I spoke to the doctor yesterday, he told me what they're doing. They're checking temperatures and they're offering hand sanitizers to the patients before they come in. And when the patients come in, they're having them socially distanced in the waiting room. So chairs are separate. And of course, you have the plexiglass, the barriers. Patients are being encouraged to wear their masks. So in terms of procedures now, colonoscopies have opened up. So patients, before they go in for colonoscopies, they have to do a COVID test. So that's pretty much what's going on now in the hospitals. If a patient has to be admitted for anything, routine elective surgery, they have to do a COVID test. So things are opening up with protocols, COVID protocols now becoming the norm. So it's much safer now to go into, you're probably safer going into the hospital for a mammogram than you are going to the grocery store. Because according to what I read, most of the spread of COVID in the UK was from people going to the grocery store. So you're much safer now in the hospitals because we're taking precautions. And I think with the onset of telemedicine, a lot of patients for their follow-up care are getting virtual visits, either video chats with their doctors or telephone calls.
Thank you. Thank you. Celestine, your hand is up. What's your question? You can put it down.
Good afternoon. Can you hear me?
Yes, we can.
My question is directed to Dr. Onoha. She made mention of the cancer patients being able to take the live vaccines.
No,
not live.
Not live.
Cancer patients cannot take
live vaccines. Yeah.
Okay. So okay, fine. So the question I want to ask is: so so what kind of vaccines do they take, and what is basically the difference between the live vaccines and whatever other variants that exist? Then the second question I want to ask is, with regards to doing your normal general checkups. You made mention of certain symptoms that you can take note of to be able to go and do your normal cancer checks. But when you are doing your normal general diagnostics to check your health and everything, is it possible for you to also, from your normal general diagnostics, to probably get a link to the possibility of you having cancer?
Okay, thank you. Those are great questions. So currently, let me tell you what's going on. When the pharmaceutical companies started their research into the COVID vaccines, the mRNA, they did not include cancer patients. Okay, so we don't have the data. However, the technology of mRNA, it's not a live vaccine. So there are certain vaccines that are live vaccines. These vaccines, the way they work, they have attenuated or live virus particles in them. So some of them that are popular are the shingles vaccine. Okay, and so this and the other one is the measles, mumps, rubella vaccine combo. Those are live vaccines. So these classically, even before COVID, we do not give these vaccines to people who have low immune system. For instance, patients with HIV, you cannot give that patient a shingles vaccine. It's not done. You cannot give that patient an MMR vaccine. Okay. You can give those patients vaccines like the pneumovax vaccine, tetanus vaccine. And those are the ones that come to mind right now. But in terms of live vaccines, because of the way they more or less sort of expose the body to some element of the virus for the person to spike a response. I can't really go into detail. I'm not an immunologist, but if there's an interest, I'm sure. Okay, so typically we do not give live vaccines to people who have low immunity. And same with cancer patients, because their immune system is low, we do not give them live vaccines, because if you give them live vaccines, they're going to manifest that condition. You know, if you give somebody with immune suppression shingles vaccine, they're going to get shingles. So that's a no-no. So in terms of the COVID vaccine, right now, the mRNA is not a live vaccine. It's using messenger RNA to send signals to the cells to make spike protein to attack virus that comes in. So as far as we know, it's safe. And for right now, experts are saying that it is okay to give most cancer patients, but that would be a decision that the patient has to discuss with their doctor. Each circumstance situation will be different. So that's an individual decision. But right now, we just, the concern is that also if you give a cancer patient the COVID vaccine, that the cancer patient's immune system is not strong enough to mount a response. But again, it depends on what stage. You know, there's some cancer patients who have recovered, they haven't had chemo for a long time. And as far as we know, it's safe to give cancer patients. And then your other question was on the diagnostics when a patient presents with, for a routine physical checkup or annual checkup, whether cancer can be uncovered. Was that your question?
Yes,
okay.
Yes.
In fact, you know, when that is the purpose of that physical checkup is supposed to uncover things that are hidden. That is what that physical checkup is for. So we follow standard protocols when we do a physical checkup of tests that are evidence-based. You know, you don't want to just be doing tests that are not necessary, because you can expose that patient to harm, unnecessary imaging, radiation from CAT scans and things like that. So you take a directed history, and if during that history taking you identify systems that possibly could have disease, then you can focus in those particular areas. But that's the purpose of a screening physical or a general physical. It's supposed to identify disease before it manifests, but mindful that you do no harm. You know, you don't want to expose the patient to unnecessary testing, unnecessary radiation, and things like that.
Yeah, thank you very much.
You're welcome.
Thank you. I've got one more question. If there's anybody that has a question, please raise your hand so I can take it, because this finishes in 10 minutes and I won't run over. So if there's anybody, either you raise your hand or you press the raise hand on your screen so I can actually take the question. Anyway, so the main one I want to ask is, one is COVID-19 vaccine and cancer is fine. Is that correct? Is that if for as long as your doctor allows you to take it, can we take that as what is being said today?
Correct, as long as it is not a live vaccine. Currently in the United States, we do not have any live COVID vaccines. But I know vaccines are being developed constantly, but currently the ones we have, we're giving, we have Pfizer, we have Moderna, and they are not live vaccines, and they are safe to take.
Okay, so you see, simple questions are now going to be asked. And the next question I have is, for people who find themselves with any form of COVID-19 symptoms that have cancer, they should, Marion, please, can you also give a comment on this? They should be saying, go straight to the hospital and identify yourself as I have, I am, or I have had cancer, I am going through cancer treatment, or I am on maintenance drug, should be clearly stated at the point of any emergency care. Mrs.
Absolutely.
Is that correct? I'm trying to summarize now because we're finishing up on time today.
I think that's very important, because that helps to know how to go on with the treatment. So if you're a cancer patient, if you've been identified with cancer, if you're on regular treatment, if you're on any therapy, it will do you a lot of good if you come into the hospital and you let them know, because you may not be at your normal hospital where all the stuff about you is known. So it will be ideal for you to mention it at the point of call when you come in to say, I'm on active treatment, I am so. And it's so good this day because every hospital is linked now. They can retrieve all your documents and everything. So it's important to identify, because that makes us easy for us or whoever will treat you to know where to place you, how to treat you, so that you don't get drawn down and your condition doesn't get worse. Because from example that I've seen in A&E with people that have come in with cancer and ended up in an ICU, which I know some people particularly, we were very lucky. They were able to get some back because they ended up on ventilator, but some we missed. Very, very close person. We actually missed them. And when I say missed them, they passed on, they died. So the advice is, please let people know, let whoever you speak to know, I'm a cancer patient or I've suffered from cancer, and then they will know what test and which way to go forward. Thank you.
Thank you. Okay.
Can I say something on that too? I
Okay,
think
so
it's also...
Hold on, Dr. Ngozi, you're going to give the last medical comment before I shut down.
Okay, go ahead.
Go ahead, go on.
Okay, all right. So back to what Mrs. Fasogmon said. I agree with what she said. I think the patients should also make it a habit of carrying a little notebook in their handbag that details the medicines that they've had, because often the patient comes and, oh, I got one medicine last week. What was it? I don't know. So it will help a lot if you have, for instance, just a small little notebook or a small card that has something about the medicines you've had, or maybe some of your test results, especially if you've had CAT scans or ultrasounds, and just have it in there. Information about your doctor. Some people don't even know the name of their doctor. So you ask them, who is your doctor? I don't know. So so it's important to have this in a little, maybe put it in your wallet or, your handbag or whatever, or put it on your phone, put it in your notes, get an app, download an app and just write it in your phone so that you have it with you all the time. So that's all.
Okay, thank you very, very, very much, both of you, for coming on today. Thank you for your tips on COVID-19 and cancer patients. It's very interesting when I listen to both of you, because you just said something that I actually have a book, and as soon as I get home, I remove the thing from my bag, and I just realized every time I go there, I say, I'm taking a drug that it starts with or it ends with, and I don't know. And I say, but this is what it's for. So it's very interesting that you've raised the point that maybe I should have this thing on my phone now. Okay, I will do that. So for those of you like me on this platform that are living, taking the treatments, going through it, I've been through it. I've been on it for the last 4.5 years. I am still here. I did treatment this morning. There is hope, and we've got to all fight together. We've got to believe that we can make it. We will make it. It is together we stand. And for as long as we create and continue to support our own forums of encouraging people to see that we're not ashamed, it's a hard journey. We're not going to tell you lies. Having the support we have, we are very appreciative. I keep saying it on this platform, of all our family and friends who really stand by us at this time. It is also a very interesting time when we can actually start talking about it. Cornwall Cancer Foundation was founded, and one of its fundamental issues is to create a platform that says, let's talk about cancer. And you don't have to identify yourself when you're on a platform. All you can do is raise your hand, send a message, whatever, just ask for help, please. Although we're doing it as an international today, a lot of the time we also do have a lot of people from Nigeria and West African countries who do not have the facilities, but we have advisory boards online that work with us and work in, one of our advisors is in Northern Nigeria, one of them is in Abuja, one of them is in Lagos, and they can help whoever is on the platform, directing them to what help they can have or who they can talk to while they are in Nigeria. So it's creating, we are building, it's a young foundation, and we hope and we are going to continue to sustain Let's Talk About Cancer. So the next one is coming up in the next 4 weeks, and we'll share the details. As long as we've got your details, we'll send you the info for you to register. We won't register you, we won't send you anything. we'll want you to register yourself, because we don't want to bombard people with registrations. If you want to be there, you will be there. It is us fighting and creating an awareness. So Common Cancer Foundation wants to thank both of you, Dr. Ngozi and this is Fashogmo, because I know I'm three different ways, so it's very difficult to get which one I'm trying to work with. Okay, both of you for working with us, for talking to us today. We really appreciate you. We really appreciate the fact that you've given us time. I want to say to everyone, you can find us on Common Cancer Foundation on our Instagram page, on our Facebook page, and you can get information from our website, www.commodcancerfoundation, it's one word, .org. And we also have a YouTube channel where some of the videos that we have done are also on, that can be shared, and you can subscribe to them. The main fundamental purpose of Common Cancer Foundation is to create an awareness. That's fundamentally what we're trying to do. And you will see videos that you can all share in Igbo, Yoruba, and Hausa on various cancer, what do you call them? Days that have happened. So January, we did have cervical cancer in Igbo, Yoruba, and Hausa. You can find on our Instagram page or Facebook page. You can also find all our videos all around. And if you want to participate in helping us to develop cancer videos, please get in touch with us, DM us, and we will get back to you. We need to agree to be a community fighting cancer together and working it together so we can help all of us in our small community to become fighters. Let's fight cancer. Let's beat it together. I want to thank you all for coming on board today. Thank you for logging in. And we look forward to seeing you again at the end of the month. Have a lovely day. I'm back. I'm all right now.
Take care.
Bye. Bye. Thank you, everyone.
Thank you very much.
Thank you, everyone.
Very interesting meeting.
Thank you.
Thank you very much. Very interesting.
Well done, Denise.
Thank you.
Bye, Dr.
Bye.
Thank you.
Bye.
Bye.
Thank you so much.
Thank you.
Bye.
Very interesting. Thank you, everyone. Really appreciate.
Thank you. Bye, Denise.
Bye.
Bye, Denise.
Roy, you are here.
I'm here now.
Yeah, in hiding.
I can't show my face before you said I didn't come.
Ngozi didn't see you. You hiding your face now.
No, I've been,
I know you are well. So I'll say thank you.
Bye, Auntie Denise.
Sorry, I'm glad you did it that way. I was able to log on at the time.
No problem. Okay, we'll catch up anyway.
Yeah. I hear you. Yeah. Thank you, everyone.
No problem.
Thank you, Sister Denise. Well done. You're doing a marvelous job.
Small.
Yes, as well. God bless, ma. Bye.
Umi.
Yes, Auntie Denise.
You didn't say anything. Well done. Seb.
Well, I was trying to work out if 3 o'clock Nigerian time was different to blasted 2 o'clock English time.
You know that you're on the Zoom. So before you start saying unnecessary English here, just know that you're not the only one here. So if you like, you run your mouth anyhow.
Well, because I came back from my walk especially for the meeting. So then I wasn't sure, but I'm glad I caught it.
Happy New Year, Seth. It's Angela.
Hi, Angela. How are you, my darling?
She has gone off again now. She goes
okay.
I'm fine, thanks.
Oh, good. Happy New Year, my sweet.
Yeah, same to you. It was nice to see you this year. Last time I saw you was in 2020.
Was it even then? I think it
yes,
was.
It was at the hairdressers.
Oh yes.
Oh no, it was. Was it? No, was it? Was it?
No, I think it was 2019.
Yeah, Christmas time. Yeah.
Excuse me. My thing is
recording. Sorry, Seth. Yeah.
Juliet, I don't know where you are. Take care of yourself.
Right, I'm going. Nice to see people. Next time I'll be more prepared.
Now you know how to talk on your phone, right?
Bye.
Seb?
Yes, honey.
You know how to find it on your phone now when you get messages.
Well, exactly now, because I told you it came through at 6 o'clock in the
It
morning.
doesn't matter when it comes through. It's because of
Yeah,
when
as long as it's, yeah, exactly. Now it's here. Yep. Take care, darling.
Take
Bye.
care.
Bye-bye.
Bye.
Bye, everyone.
I'm trying to leave, but I can't leave.
Don't worry, I'm shutting.
Okay.